Welcome, everyone, to this month's BJJ podcast. I'm Andrew Duckworth, and a warm welcome back to you all from your team here at the Bone and Joint Journal. As always, we would like to thank you all for your continued comment and support, as well as a big gratitude to our many authors and colleagues who take part in the series that highlights just some of the great work published by our authors each month. So today for our podcast, I have the pleasure of being joined by two authors from an editorial published in the April edition of the BJJ entitled Periprosthetic Joint Infection, Navigating the Literature. So firstly, I'm very pleased to be joined by Mr. Ian Kennedy, who is an arthroplasty fellow in Vancouver at the moment. Thank you, Ian, for joining us. It's great to have you with us.
Thanks, Andrew. It's a pleasure to be here.
Secondly, we have the pleasure of being joined again by our awesome editor-in-chief here at the Journal, Professor Faraz Stab. Prof, great to have you back with us.
Andrew, thank you, and thanks for coordinating this.
Prof, I thought we'd maybe kick off with yourself, and I was hoping maybe you'd give our listeners a brief overview of the current state of the literature in the PDI, what sort of PGI, and what sort of is topical, and any recent advances that you wanted to highlight.
Yeah, thanks, Andrew. I mean, it's a really buzz area. It's one of those areas where there is desperate need for innovation and progress, and one of those areas we probably haven't focused our attention enough. So I think if we look at the last few years, I think we've generally made a little bit of headway because there's been more interest in this area. On the diagnostic side, probably the key things have been things like sonification, polymerase chain reaction, biomarkers. They've had their ups and downs, but essentially they're becoming established as part of what we can do and aiding the diagnostics in infection centers. Probably the biggest thing for me has been the shift to patient-centered care in single-stage revision. So the research that has shown that single-stage revision has a real place, perhaps an equivalent or better place than multi-stage surgery, has been a big contribution. And likewise, and I think now we're seeing some literature on DARE reappearing and its role, something that was quite popular in the UK, perhaps confused with incision and drainage elsewhere, and not necessarily as widely applied. And all these places are going to sort of find their home, but there's good literature there. Yeah. And I think that there's hope in many areas in terms of, the intraosseous antibiotic story. That's really interesting. Yeah. Is that, what place does that have to play? Is it a revision thing? Is it a primary thing? What are the indications? But, understanding that, there's been some good research around that. I'm really excited about what happens with implant coatings. Yeah. Because I think there's been huge progress, limited partly by the regulatory framework, because anything that elutes becomes a real problem in terms of the regulations, but actually the potential there is massive. That'd be a game changer across all aspects of trauma and orthopedics. And then things like hydrogels and potentially, bacteriophages has suddenly become a buzz thing. So, I think whilst, we've written this editorial and I've spoken over the last couple of years quite a lot on the weaknesses of the infection literature, and there is some positivity out there, and there's been some good progress in these areas.
Yeah, that's a really nice overview, Prof. And maybe if I come to you next, Ian, because I think Prof sort of set us up well there about the current state of the literature. But as you highlight in your editorial, despite these advances, there's been some maybe a perceived little overall improvement in success rates, and there are some issues with the literature itself. And so maybe we could go into those in a little bit more detail. With regards to the type of studies, whether they're single center, multi-center, what's been the issues with that in the PGI literature?
Thanks, Andrew. So firstly, I should say that single-centre studies are undoubtedly an important component of the PGI literature. They provide us with in-depth insights into institutional protocols and surgeon expertise, but their narrow focus can limit generalisability. For example, the patient populations, MDT involvement, and surgical techniques employed at a tertiary referral centre may not be reproducible more widely across the whole healthcare system. Also, the majority of studies come from a limited number of specialist centres who may publish multiple analyses from overlapping cohorts. And so this can lead to skewed perceptions on the effectiveness of certain treatments. Karsten Perke's work with the German registry that was published in the BJJ highlighted that perfectly. There's also the issue of small sample sizes that are inherent to single-centre work. We know that PGI is a particularly complex area with multiple variables influencing outcomes. And so adequately powered studies are required if we're able to draw reliable conclusions rather than coincidental ones. I mean, ultimately, we're trying to improve the quality of treatment we provide, but without high quality evidence and rigorous methodology, it can be difficult to know if we're heading in the right direction.
Yeah, no, absolutely. And I think as part of that, which again you touch upon in your editorial, is how we measure success. How are we measuring the outcome of PGI? And you highlight some interesting issues with just looking at something like for revision rates, for example. Can you just go into those in a bit more detail for us?
Yeah, that's a great question. Revision rates are obviously important, but focusing solely on this paints an incomplete picture of treatment success in PGI. I think it's natural for us to focus on return to the operating room as a proxy for success, but it potentially overlooks domains that are more important to the patient. For example, mortality, it's something we often don't look at very much, but midterm death rates after septic revision have been reported as up to 45%. And patients who die before second stage reimplantation are often excluded from success calculations. And so this not only highlights the true significance of a PGI diagnosis for patients, but also can lead us to underestimate the true failure rate of our interventions. But additionally, we need to consider patient-reported outcomes, as Prof has mentioned. It's not frequently reported, but as we know, PGI can have a profound effect on quality of life, mental health, and being able to live independently, even in cases deemed infection-free. The great work that was done by the INFORM group highlighted the importance of placing patients at the centre of defining success. And so without capturing these metrics, we're underappreciating the broader impact of PGI and failing to report on what success and failure truly mean.
Absolutely, and we'll come full circle to that towards the end of our podcast today, talking about some of the work that you and Prof have done. But maybe, Prof, I could come back to yourself. Some of these issues, some would argue, could surely just be addressed by either using registry data or or well-designed RCTs. And obviously, that's something we obviously advocate here at the journal. What are your sort of thoughts on that?
So I think that's been something people have been looking to do, and there's a literature out there looking at registries for infection. I think it's partly problematic. It's something that's improving. The reality of registry data is that it is often recorded at the time that the surgery is performed, and therefore it doesn't necessarily record whether there is confirmed infection. It could be suspected infection. It could be superficial or deep infection. Doesn't record the organism. Then there's the sort of fidelity of the intervention that's performed from that point of view. And most registries haven't been linked to pharmacology databases or other databases that would look at treatment allied to that. So I think we know even from the Danish registry, who've looked at it in a very honest and transparent way, that probably at least 40% of infections are not being picked up by the standard registry process. So whilst it is, I have to say, the registries are quite useful at looking at trends, looking at the sort of demographics of infection management. That's been done quite well from our own sort of UK registry. They're not the perfect vehicle unless they have a much deeper, detailed data set that's infection specific. There are now attempts to do that, and it's almost. I remember when the infection registry was being set up in the UK, suggesting at the time you almost wanted infection centres to come together and have a much deeper, much more detailed, granular set of data. Because if you look at the registry outputs, I mean, probably the biggest danger, which I don't think we mentioned in our editorial, is the sort of output we had from the New Zealand registry on laminar flow theatres and infection rates, where in reality, what the registry was capturing was the laminar flow in the hospital rather in the operation. We didn't even know if it was on or off. And, that's led to guideline changes, all sorts of things. So I think we've got to be careful from that point of view.
Absolutely.
But I think the registries, and the work that the Bone and Joint Infection Registry is doing in the UK are going to be a step in the right direction. We do need to study this on a population basis. One of the things that will help with this, certainly in France, in the UK, and I hope increasingly elsewhere, is the sort of network solution of infection management. Because
Yeah.
if you can cohort more of these cases in big centers that record their data better, we will start to understand the bigger picture, understanding polymicrobial infections, understanding fungal infections, so on and so forth, from that perspective.
Absolutely, Prof. And Ian's already mentioned it. Moving on from sort of registry work, there's obviously the Inform trial, which is an example of an RC, a trial in this area, isn't it?
I mean, I'm a huge fan. The sort of what Inform has done, and this is not one paper. This is a
Yeah.
multitude of outputs. They focused on the patient, as Ian said, and having the patient front and center. If you may remember in the journal, we coined the expression "even the winners are losers,"
Hmm.
because surgeons may be congratulating themselves on an ablative procedure that controls the infection, whereas we've got an unhappy patient. So whilst there is some criticism of Inform for having a PROM as the primary outcome, that's of course required by NHR and IHR, and ultimately that is the correct metric. What we're looking at is, do we have a happy or an unhappy patient? Do we have a functional or non-functional patient? So I think Inform's been critical in supporting the message that single stage is perhaps a cheaper and more patient-friendly way of delivering the same outcome. And likewise, that's why I think this is not about the literature, my personal thesis is that infection management needs to be bespoke for that patient at that time in that institution. What's the best care that can be delivered?
Yeah.
What are the dangers of delivering something more invasive? And what will the patient be happiest with long term? And what happens if the current strategy fails?
Yeah.
So I think Inform has been a huge contribution. And it also demonstrates that in this very, very difficult area where there are extremely loud opinions, it's possible to actually do a good randomized study.
Absolutely. No, I couldn't agree more, Prof. And like you say about the patient being the center of it, I think there's so much justification for that, like you say. And before we maybe move on to looking at some of the core outcome set work that you and Ian have done, a big question which I know you've talked and written about a lot before is that key question of the diagnosis, diagnosing PJI. And there's been quite a lot of work and quite a lot of evolution even over the past decade with regards to this, hasn't there?
Yes, no, it's been an intriguing area in the sense that in 2013 we had reasonable consensus around the MSIS definition. In fact, at one stage shortly thereafter, Ian Stockley, myself, Samu Sedik, and others came out with the idea of creating something that quantified that in a numerical way.
Yeah.
And that is still a sound idea if we had the building blocks absolutely right. I think the reality of definitions is we need one unified definition, and we must stop changing the definition because otherwise the literature becomes very flaky.
Yeah.
I think we took a big backward step, in my opinion, in 2018 when a sort of consensus definition came out prior to the consensus, based on data that many of us still don't completely recognize and understand. D-dimer coming out of nowhere, huge overemphasis on alpha defensin, and underplaying of culture, which is I think still at the heart of what we should be thinking about infection wise. So that created a bit of confusion, and that's why at the journal we've kind of landed on the EBJIS definition, which is pragmatic, sensible, agreed by the majority, and is probably the current standard that people should be using until there is universal agreement over something better. And just remember, we cannot keep chopping and changing. So I think we've got 2013 is still a sound background. Moving forward, EBJS is a good place. Others will come out, but it's been a tricky period with that. There's no doubt we all need a place to land on that we can agree on, but I don't think we're there yet.
No, and I think it's a really lovely overview, Prof. But actually, like you say, it's so important to get that right, isn't it? Because then all the literature really hangs off these definitions and also the outcomes as well, and getting them right. And that sort of leads me nicely back to you, Ian. If I could, maybe just to finish up with you and Prof, is just to very briefly cover your other publication, which is in the April edition, which is entitled PGI Development of a Core Outcome Set. Can you just sort of give our listeners a brief overview of that paper and what it found?
Certainly. So as we've discussed, the variability in outcome reporting makes it difficult to compare studies and conduct meta-analyses. And so by developing a core outcome set, which is essentially a minimum agreed upon set of outcomes that should be reported in all PGI studies, we set out to standardize reporting. Mm-hmm. To obtain consensus on what outcomes should be reported, we undertook a two-stage Delphi process. Stage 1 involved a core group of 9 experienced PGI researchers, and importantly, it also included 5 patients to include the perspective of those with lived experience. This was performed to firstly develop the key domains and outcomes, and involved online voting and a virtual meeting. In the second stage, we expanded the Delphi process and invited over 80 international stakeholders, including surgeons, infectious diseases clinicians, and academics, to vote on the core outcome set developed in stage 1 and finalise it. So this resulted in 23 outcomes divided into 4 key domains. The first domain was patient demographics, such as age, sex, comorbidities, immune and soft tissue compromise. Secondly, infection characteristics, including chronicity of infection and infective organism. We then noted surgical and treatment details, for example, operative technique and antibiotic therapy. Finally, outcomes and follow-up. This domain addresses factors such as reoperation rate, patient-reported outcomes, mortality, and follow-up period. And ultimately, our hope is that by providing a comprehensive and practical guidance for future PGI studies, we can lay the foundation for more consistent research.
Absolutely, and I think it's a fantastic piece of work for that very reason. Actually, so needed from what the discussion we've had. So, Prof, maybe I could finish with yourself. Just sort of a two-part question. I mean, the first thing, just your thoughts on the core outcome set and what that sort of added to the literature, and the ability to perform research in this area. And what do you feel is the next steps? Where are we headed in PGI research?
So thanks, Andrew, and thanks again for raising this very important topic.
Yeah.
The core outcome set is something I've been keen on for a long time. And as ever with these things, you need people with energy. And it's been great to have Ian and a few others willing to drive this forward, because I think we do need to standardize. We need to create minimums, and we need to essentially set a bar for what infection papers should look like as a minimum. And if we go back to our earlier discussion, the Charité, the paper from Carsten Perker and Ressel and the team looking at the German registry linkage with the insurance database is salutary, because many people regard the German management, particularly certain the big centers there, as the standard that's taught us how to manage infection. And yet this manuscript brings into question a lot of the data, including some of the data that's been published in the journal previously. It really does. So any reporting now needs to be to a minimum standard. And I think that core outcome set should be generally adopted by all those who are interested. And that should be the minimum that they input. And then, moving forward, that'll be one of the many pillars of improving infection research. I think at the heart of all of this, probably the most important thing is prevention. So, really focusing on that area rather than just the sort of management that's interesting to surgeons will be really important for the future. So I think really let's look there. Let's look at those surfaces. Let's look at what prophylaxis we're giving. Let's look at how we're managing and optimizing our patients, et cetera, from that point of view. And then larger and larger scale studies, and hopefully some more RCTs, particularly as infection services are centralized. I think the one thing that's for sure is certainly in arthroplasty surgery, which is the area I'm most focused on in my own work, we kind of have solved many of the other failure modes. Infection's the one we've got to really capitalize on for the next 10 years in order to improve what we deliver to our patients.
Absolutely, Prof. And that's a very good take-home message. And I would really echo your comment about, I think, not just here, but throughout medicine, we spend so much time focusing on intervention and treatment that actually prevention is surely the better mode for a lot of what we deal with in medicine. Well, both, I'm afraid that's all we have time for today, but thank you to you both so much for taking the time to join us, and congratulations on I felt a really interesting editorial and a great study which has clearly added a really important benchmark, I think, in the PGI literature of how these things should be reported moving forward and carried out. It was great to have you both with us. And to our listeners, we do hope you've enjoyed joining us, and we encourage you to share your thoughts and comments through our social media platforms and the like. Feel free to post about anything we've discussed here today. And thanks again for joining us. Take care, everyone.